This video illustrates right hepatectomy using hanging maneuver for right lobe hepatocellular carcinoma. This 63 years old gentleman was found to have tumor in his right lobe of liver while he was investigated for his upper abdominal pain. His LFTs, viral markers, and tumor markers were normal. His triphasic CT scan showed a 9.9 by 6.7 by 9.6 cm tumor in his segment 7 and segment 6. It has an exophytic component with intrahepatic rupture with some collection in the right subdiaphragmatic region. You can see the CT scan on an arterial phase shows a hypervascular lesion in segment 7 and in segment 6. In the sagittal film, we can see in near segment 7 there is a subcapsular rupture and collection in the subdiaphragmatic region. A J incision was kept. The falciform ligament was divided. The small hepatic veins were ligated and divided. The infrahepatic infravena cava was dissected. This is the suprahepatic dissection between the right hepatic vein and the middle hepatic vein. You can see a space is created between 10 and 11 o'clock in the front of the IVC. We need to create a space in this avascular plane which is there in the front of the IVC between the liver capsule and infravena cava. The space is created from above as well as below. A blunt artery forceps is used to create this space. The long artery forceps is now inserted in this avascular plane and is palpated in the suprahepatic space between the right and the middle hepatic vein. A nasogastric tube is passed in this area in front of the IVC without mobilizing the right lobe of the liver. You can see the nasogastric tube is passed from above to below. The hanging maneuver is an important maneuver which is used mainly for the anterior approach where there is a large tumor or when the tumor is involving the diaphragm and it is dangerous to mobilize due to fear of rupture in such kind of tumors. You can see sling is passing in front of the IVC. Cholecystectomy is performed. Now the right hepatic artery is dissected and slinged. Now the right branch of the portal vein is dissected and slinged. The snugger is applied on the right branch of the portal vein and the right hepatic artery is clamped. The line of demarcation can be clearly seen on the liver surface. The line of transection is marked with the diathermy. The stay sutures are taken on both the sides and parenchymal transection is performed. The parenchyma is transected with the help of ultrasonic aspirator, bipolar and monocolor cautery, ligature and clips. Now the right hepatic artery is ligated, transfixed and it is divided. An intraoperative ultrasound is performed. Now the right branch of the portal vein is clamped. The right branch of the portal vein is divided. The stump of the right portal vein is sutured in 2 layers with 5-O-proline. This is the right bile duct. The caudate lobe is divided. You can see the sling is now used as a traction to guide the area of the transection in this patient. This is the right bile duct. The right branch of the bile duct is divided intrahepatically. A Watson chain dissector is used to see the patency of the bile duct. Parenchymal transection progresses further and cranially. You can see here this sling is used as a traction to guide the area of the transection because here the right lobe of the liver is not mobilized. This is extremely important guidance by the traction. Now you can see the IVC at the bottom end, and this sling is guiding to the area of the transection. A small bit of parenchyma is remaining in front of the IVC. Once we divide this nasogastric tube will come out. You can appreciate the exposed anterior wall of the inferior vena cava. The small right inferior hepatic veins are now dissected and divided. You can appreciate the small right inferior hepatic veins. The next step is to carefully mobilize the right lobe of the liver. The ligaments are divided and the right lobe is carefully mobilized. The right hepatic vein is clamped and divided. The specimen is removed. Right hepatic vein orifice is closed with fibrinoline in 2 layers. This is the area on the right subdiaphragmatic region which had a tumor adherent to it and a small subcapsular rupture. The right branch of the bile duct was closed with 6-PDS. A methylene blue test was performed to see for the bile leak. Intraoperative cholangiogram was performed. Cholecystectomy was completed. This is the transection surface. This is the inferior vena cava. Thank you.